lumbar interface mobility. Think about it such a comparison.
First of all, a very warm good morning to all my dear delegates, respected chairpersons, respected judges and the organizers for giving me such a wonderful opportunity. A study on manual examination versus radiological examination in the assessment of lumbar intervertebral mobility in asymptomatic subjects. A comparative study. Introduction. Lumbar spine has been identified as the single most important cause for all the mechanical low back pain. We know that for a proper treatment, the physical examination is very important, and in the physical examination, manual examination, especially the segmental analysis, will give a clue to the level of the vertebra that is affected, and to also to localize the lesion that is present in the patient population. Radiological examination is also useful for evaluating the low back pain subjects, especially for ruling out trauma and also for finding out the degenerative changes and associated congenital anomalies. Statement of the problem. Radiological examination is definitely considered as a gold standard in the assessment of the intervertebral motion, but it has its own limitations in sense of the exposure to the radiation hazard, and its cost matters. Manual examination by the central post-anterior pressure, graded using the joint plate grading scale. It's a scale from 0 to 6, which we'll be seeing it in the next section. It was not compared to any other measures in the earlier studies. This is similar to a scale which is like a manual muscle testing. So you have a nominal ordinal scale it is, bivariate, both sides it goes, but it was never analyzed earlier in the present literature that is available. Purpose of the study is to compare the intervertebral mobility measured using the flexion extension radiography with that of the manual assessment using the central post-anterior pressure at the lumbar spinal levels L1 to L5. And also to study the application of the joint plate grading scale in the assessment of the lumbar intervertebral mobility. Findings. Hypothesis of the study. Findings of radiological examination using the flexion extension radiography will be comparable to the findings of the manual assessment using the central post-anterior pressure. The second hypothesis, joint plate grading scale will be a clinically and easily applicable tool to quantify the intervertebral mobility assessed using the central post-anterior pressure. Significance of the study, manual examination using central post-anterior pressure would be a valuable clinical tool in the physical examination of the lumbar spine. Joint plate grading scale would be an easily reproducible clinical measure for assessment of the intervertebral mobility. Review of literature. The study done by Abbott and Mercer in the New Zealand Journal of Physiotherapy 2003, they found on the evaluation of the hypomobility, the restricted mobility in the lumbar spine at different levels, and they compared radiologically with the clinical assessment, and they found that the accuracy was encouraging with adequate validity and accuracy. On radiological measures, Indian Journal of Aerospace Medicine, it was done by Wing Commodore E. Alam in the year 2002, and he concluded that the functional radiography is a simple and reliable tool for measuring movements at a spinal motion segment. White and Punjabi, the literature 1978, has prescribed some criteria for the normal mobility. As the criteria L1 to L5, the translation measurements were kept at 3 to 4 millimeters as the normal, and the rotational measurements 13 to 15 degrees as the normal. The difference definitely is obvious in the L5 to S1, where there is increased mobility biomechanically in the angular displacement, that is the 20 degrees, which is also considered as the normal. The translation, however, is same, that is the 3 millimeters normal. The type of study design is a cross-sectional study. Testing instruments that were used is the screening or the evaluation form for the clinical examination, just to rule and find out whether the subjects were really able to participate in the study. Joint plate grading scale, a ruler just to measure the translations clinically, and protractor to measure the angular displacements. Subjects, they were asymptomatic subjects, 5 of ageless sex, 4 males and 1 female with mean age 20 plus or minus 1.9 years. Informed consent was obtained from the subject for the participation in the study and was done through convenient sampling. Excluded subjects where they had a history of the neuromuscular skeletal problems in the lower quarter from the lumbar spine, pelvis, hip, knee, or the foot and ankle, or they were unable to participate in the study because of the testing position, that is the prone for the assessment of the central postprandial pressure. Procedure. The testing was done in two parts. Either the radiography was done first or the manual assessment was done first after the clinical examination, and this order of testing was randomized to all the subjects. And after the radiography is done, the flexion extension radiography, the image was traced to a transparency, and the measurements of the translations and rotations were done by marking the vertebra, by tracing the vertebra, and by marking the posterior most margin for measuring the anterior translations, and the anterior most margin for measuring the posterior translations, and the lines that are parallel to the vertebral bodies for measuring the angular displacements. And then manual assessment of central postprandial pressure was done with the patient lying prone, with the therapist applying pressure vertically to the spinous process and from L1 to the L5. Grading of the intersegmental mobility was done using the joint plane grading scale. This is X-ray of the lumbar spine in flexion, neutral, and also in extension. For the measurement of anterior translation and the anterior rotations, the posterior most margins of the vertebral bodies. Okay. And for the posterior translations, we mark the anterior most margins of the vertebral bodies, and for angular displacements, you can see that it is marked by the surface to the vertebral bodies. Technique of application of central postprandial pressure, you see that the vertical application with the cross band techniques are what is called as the pisiform grip. Joint plane grading scale, 0 is graded as ankylosed or rigid, 1 is considered as considerable hypomobility, 2 is graded as mild hypomobility, 3 is graded as normal mobility, and 4 as mild hypermobility, and 5 as considerable hypermobility, whereas 6 is considered as unstable. Data analysis. The joint plane grading scale score was correlated with the radiological measurements of anterior translation, anterior rotation, posterior translation, and posterior rotation at the respective spinal levels using Carl Pearson's correlation coefficient with p-value set at 0.05 as a level of significance using the SPSS 12.0.1 for the Windows software. Results. You can see that the levels L1 was analyzed separately, L2 was assessed separately. Okay, the respective levels were analyzed separately, and the first column shows the correlation between the joint plane grading scale with that of the anterior translation. Second column shows joint plane grading scale with that of the anterior rotation. Third column shows joint plane grading scale with that of the posterior translation, whereas the fourth shows the joint plane grading scale with that of the posterior rotation. The first and the fourth column, you will see that the L1 to L5 across all the 5 subjects, there is a level of significance of point value, p value that is less than 0.05, correlation coefficients which is greater than 0.9. Discussion. The current study has following implications. In one sense, first, in the results, we saw that the positive correlation existed between the anterior translation and the joint plane grading, and also the posterior rotation and the joint plane grading. So, it may be because of the mechanics of the central postprandial pressure. The central postprandial pressure produce anterior translation and also posterior rotation. And we check both simultaneously when we apply manually. So that might have caused the correlation to come in favor of the joint plane grading scale for those movements compared to the other movements which are not checked mechanically by the central postprandial pressure. Validity of the joint plane grading scale, because radiological measurement is expected to be the gold standard in the assessment of the lumbar intervertebral mobility. So this scale, if it is comparable and if it bears a positive correlation, could be examined further for a validity in a larger sample size, which is however the limitation of the present study with a smaller sample size. And the manual assessment of intervertebral mobility is important. The study is done on normal subjects, but the study could be extended to even the low back pain subjects. to compare between the subjects on the nature of the intervertebral mobility. Conclusion: the study showed that manual examination of intervertebral mobility using central post-arterial pressure was comparable to the radiological assessment of the intersegmental mobility of the spine in the 5 subjects that were studied. The significant correlation was noted between the grades of intervertebral mobility assessed using the central post-arterial pressure and the anterior translation and the posterior rotation measurements. Thank you so much. I thank specifically Professor Dastur ma'am and Dr. Dilip A. Patel for giving me such a wonderful opportunity to present in all in front of you. Wish you all a very, very happy new year. Yes.
Is this a study on normal?
Yeah, the study is on normal.
Why did you have such a small sample size of 5 studies? I mean, to even talk about significant or non-significant correlation or whatever. I think the sample size should have been slightly more.
Definitely, it should be more when we try to compare between 2 tests. But what was felt was the clinical examination. We wanted to rule out those with severe hamstring tightness, like beyond 45 degrees. Reflexor tightness, which is beyond 50
But you have
degrees.
got many normal subjects with fitting into that criteria.
Clinically also we told the subjects to be normal rather than taking tests they are asymptomatic.
Right. But
So
I
that's
think
why
you
we
would have got
became
many subjects who would have fit into that criteria, isn't it? So I think the sample size should have been slightly
the
more.
observation that was asked in the part of the study was, we saw that most of the normals who are asymptomatic also they have abnormal features when they have the clinical examination that's being done on them. So we could not include them in the study.
One more thing is, you said you had randomization of the assessment.
Assessment procedures.
How did that help?
If, for example, I assess radiological examination first on a subject, another subject I assess the radiological examination itself on the another subject. Okay. For example, the change of exposure to the test will alter the response of the patient, according to the statistics. So if we randomize the order of the testing, like you see the test 1 and another subject test 2, you just randomly allot, then the bias is avoided in the study.
But you only did the radiological assessment as well as the joint pain.
No. Clinical examination was done by another physiotherapist who ruled out.
That was not mentioned, right?
That was not mentioned. Actually, radiological assessment is done by, it was performed by a radiographic technician, and the assessment and the measurement was done by another physiotherapist who is qualified, and there are totally 4 testers in the study.
In your joint plate radiation, you have mentioned considerable mobility. What do you mean by that?
Considerable hypermobility or hypomobility?
Both. Where do you draw that line?
Draw the line. The clinician's perception of the resistance, okay, that's what matters when you assess the intersegmental mobility. That is graded as grade 3 by the grades of mobilization. So clinician checks either for a pain response, which you do not expect in the normal subject. So we check for the resistance, which part of the range it comes. If it comes earlier in the range, it's graded as hypomobility. But you expect the resistance at that range, but you still do not get the resistance. Still the range of movement is still going in. Then you grade it as a hypermobility. In that mild hypomobility, if you get a range of movement and then you get the resistance, mild hypomobility. If you don't get a range of movement, the resistance comes in the earliest part of the range, then it is considerable hypomobility. Ankylosis, when you apply the pressure, you feel like you are applying on a rigid bone. This is ankylosis. There is totally no movement. Unstable is when you apply pressure, you just keep your thumb or your pisiform, you will feel that the spine is totally unstable. Visibly there may be a step or a hyperlordosis. When you start applying pressure, the clinician is intuitively guided that he should not apply further pressure because the spine is totally free of resistance right from the beginning. That is graded as unstable.
Have you included 80 joints together with the what is the Examination doesn't reduce the equipment hypermobility or hypermobility. Right?
The radiological examinations, as stated that the person is going to fall below the normal mobility or above the normal mobility, because the normal grading has been defined. Normal values have been defined.
I am talking about the manual examination.
Manual examination. AP, no. AP for lumbar spine is not reliable. It is not being well established in the literature. That's why we did not include in the study. Postero-anterior pressure is a commonly used evaluation method. So we wanted to establish it in terms of its effectiveness to improve the evaluation in the spine especially.
Do you think any pathology of equipment is hindered or
The pathology of posterior translation will come in anterior restraint failure. If you want to call as anterior longitudinal ligament or anterior annulus in the spine, if it is affected, then posterior translation will increase. Posterior restraint failure will lead to increased anterior translation. Posterior restraint failure is most common. You see that posterior annulus tears or posterior longitudinal ligament tears, very common. Clinically more important, ligament, all are posterior structures. Most painful structures in the lumbar spine are also posterior structures. So somehow it was felt it will be more clinically. Yeah, we ruled all the patients with symptoms.
for example, the person doesn't have a symptom, doesn't need having, you don't need having number, increase number or that posture. So, does it interfere with your study?
Yeah, definitely. Actually, the neutral radiograph was also assessed for the lumbosacral angle and the sacral inclination angle. If both these angles are measured, just to make sure that all the subjects have around near it is equal measure. It was also part of the clinical evaluation, but it was not part of the inclusion criteria. It was done as part of to include the subjects to be with similar nature. Anybody else?
Okay, this is for higher subject. Looking at the justifying the statistical test.
According to the statistical test, the power of the test is not met.
Yeah, you're taking towards the type 1 error, majorly. That's one. Two, I mean, yes, this needs to be very good in your manual therapy technique, and but what about the reliability? Did you measure the reliability? I guess there was just one person who was doing radiographic evaluation, and the other person was doing the manual evaluation. So what about the reliability between two measures? Because before you correlate between one method and the other, your reliability for the same has to be tested. Did you test that?
We checked only the intra-test reliability, but inter-tester we did not check. That means his repeatability. For example, he checked at one point of time, and then he does not know the subject actually. He is blinded from the study design, the one who measured the radiological measurements. And he checked one day, and again he checked the other transparency which is traced again, the image traced. So intra-tester, that is the test retest, that reliability was checked as part of the study. And trials were conducted for the central post-anterior pressure on different days, just to check the repeatability of the grading.
Okay, if you haven't mentioned that, this is a very big thing, you know, especially when you're comparing two different methods. And, maybe I'll ask you.
Yes, thank you. I just want to ask last question. On radiograph certificate, standing or lying down technique?
It is actually as per the procedure that is described. The flexion radiograph is taken with the patient is sitting on a higher plane, which when he is flexing between his legs. Okay, and the neutral one is taken with the patient in standing, lateral, and the another one, the extension one is also taken in standing with the patient arms held at around extended position, extended back position.
Okay, and they are all sort of digital accurate? Or the ordinary radiographs, but the digital accuracy, because the digital gives more accuracy.
Yeah, digital will definitely give accuracy, but these were ordinary radiographs only, plain radiographs.
Okay, thank you. committee and Manoj sir on his behalf as well, giving us opportunity to share this lesson. Thank you organizers for again.
Thank you all the speakers. Now request Dr. Bharat sir to present the certificates to the speakers. And we have Ms.